Hi, everyone, and welcome to this Black History Month conference hosted by MS Focus, the Multiple Sclerosis Foundation, and made possible with support from Genentech. I am your host, Kimani Hendricks, Multimedia Communications Coordinator for the Foundation, and I'm joined by Doctors Tirisham Gyang, Jacqueline Rosenthal, and Jakai Nolan, who will be giving us the neurologist perspective of the Black MS experience. We already have some hands raised, so our attendees are jumping into the chat, and I am so excited for the discussion. But before we get into that, if anybody is joining us for the first time, if you do have questions that you would like to ask the panelists, we do advise that you add them into the Q&A or chat boxes if you're on Zoom with us. You can also use the raise hand feature here as well. And if you're tuning in from Facebook, you can type your questions into the comment section there too. Now, I would like to have the doctors introduce themselves. Can we start with Dr. Gyang and then jump to Dr. Nolan and then Rosenthal?
Good evening, everyone. I am Tirisham Gyang. I often go by Tiri Gyang. I'm an assistant professor at Ohio State University. I am a neurologist. I am an MS specialist. I love talking about MS. I love engaging with patients, other doctors that, are interested in MS, and I'm really excited to be here this evening.
Dr. Nolan?
Hi, everyone. I'm Dr. Jakai Nolan. I am also a neurologist who's a fellowship trained MS specialist. I am currently practicing in Georgia with a community hospital system called Tanner Neurology. I'm the adult neurology chair here. Smaller kind of rural area, but still wanting to make sure that we're able to bring an MS specialist to the area, because a lot of people don't want to have to drive into the city of Atlanta and deal with all the traffic we have here. So I'm excited to be here and speak with everyone and get everyone's opinion about MS and Black people.
And Dr. Rosenthal.
Hi, good evening, everyone. I'm Jackie Rosenthal. I'm the one they come to fight that traffic in Atlanta. So I'm a neurologist. I am fellowship trained in neuroimmunology. I see MS patients and other neuroimmunologic disorders. I'm in Atlanta at Shepherd Center. So there's an MS Institute there, and that's where we have our clinic set up, and happy to be here and happy to have this discussion.
Thank you, ladies. We are so excited to have you, and I can't wait to just jump right in. I do want to just let our audience know that we have a few questions lined up for the panelists, but we will try to get to them and through them as quickly as we can so that we can address your questions. So bear with us. We're not ignoring you here. We're just following a system. So really quickly, I do want to ask why each of you decided to specialize in neurology and specifically multiple sclerosis. Let's go in the order that we had gone in last. So start with Dr. Gyang.
All right. So, I went to medical school not really knowing that I was going to become a neurologist or an MS specialist, but I developed a very strong interest for neurology during my medical school education, decided to go into neurology, and then during my neurology residency, I took care of a patient with MS very early on, and just making that diagnosis, connecting with the patient's family, and then following that patient through, I kind of just developed this love for MS and, started doing more rotations and, looking out to work with my MS specialist or the MS specialist at my institution. And that was how it all started. And, I ended up doing more training as a fellowship in MS, also trained in clinical research in MS. And, today that's what I really, really love to do. I really like to empower my patients In addition to clinical research, in addition to seeing patients, I do clinical research, and I also do a lot of education. I'm a fellowship director, so I also train other doctors to become MS specialists. So that's kind of the long story of, becoming an MS specialist.
And Dr. Nolan?
And before I start, I did see one question over here, where someone asked if I'm in Carrollton. I'm in Villa Rica, Georgia, but I see people in the Carrollton area, Villa Rica, things like that. So hopefully that answered your question. But for me, I am one of those doctors. I feel like a lot of us, we kind of grow up knowing that we want to be a doctor. I thought I wanted to be a pediatrician, and then I got introduced to neuroscience when I was in high school. So from that, I majored in neuroscience in college, and at that time said I wanted to be a pediatric neurologist. And then my senior year happened, and I had imposter syndrome and didn't think that I was going to be good enough or get into med school. So I decided to kind of give myself a little bit more time and move back home to Georgia. It's home for me. And I got my master's in public health at Emory. My very first day of of grad school, though, I woke up and I had blurry vision in my left eye. And also at some point, I don't really remember when now, but I also had numbness in my left hand. Fast forward, I was actually diagnosed with MS myself in September 2009. Again, very right when I started grad school, and kind of was going through this whole trying to figure out what I wanted to do and if I still wanted to go into medicine. And the way that I approached the situation was just kind of throwing myself into everything MS. I found it very interesting that, here I am, someone who was interested in going into medicine. I was already interested in neurology, and then boom, I get diagnosed with a neurological condition myself. So eventually went on and applied and got into medical school. And I did continue to enjoy neurology throughout my rotations. And in during my residency in Ohio, I did an MS rotation with Ohio Health, and I with Jackie Nicholas, and opted that, well, I learned that there's a lot more to MS and neuroimmunology than I had learned in my neurology residency. So decided to do a fellowship and move back home to Georgia to hopefully bring care here.
Dr. Rosenthal?
All right. My path was a little goofy. I always liked neuroanatomy, brain anatomy. I knew I did not want to do surgery, and so that led me into neurology. I did the majority of my training in the military, in the Army, and so when I finished, I practiced general neurology for 4 years, and I thought that's what I was going to focus on, was just general neurology. But I really like my MS patients. But being in the military, they 8 to 9 times out of 10 were separated. And so I would see them, diagnose them, and then they were gone. I really wanted to do the long-term care for MS patients. That is really interesting, the amount of treatments we have, all of the comprehensive care that can be provided. So that's really what led to me separating from the military. And I did my neuroimmunology training after that, and settled in Georgia. And that's how I've landed where I am now.
Thank you guys for sharing. Now, Dr. Nolan, I did want to ask you a question. It just came in my head, but I realize, I suppose I just didn't know it at the time, but that you have the MS perspective from the neurologist and the patient. So what is that viewpoint like for you, and how has it been?
For me, that was initially, I'll be honest, it was something that I did struggle with, if I wanted to disclose to people, to my patients. For the longest, I couldn't tell my story without crying or breaking down in tears. So, kind of going through, from a personal standpoint, going through, the grieving process of being diagnosed with MS, and trying to figure out, how that pathway will look for me. And then learning more about it from like a clinical standpoint, as a resident, and in medical school. So I don't disclose to all of my patients, but I do find myself, disclosing a little bit more to, my young patients I'm diagnosing, who are the same age that I was, maybe when I was diagnosed, or who are questioning how they will continue to do different things in their life, whether it's continue with school or, continue with their work and things of that nature. So I kind of have this gestalt of like who I in the office setting I'm comfortable with, talking to. And I never want to make the office visit about myself or try and push, the medications and things that I do. I keep that part separate, but just kind of giving them the perspective of that this can be managed. And the importance, even kind of, I was not always a compliant patient. I went months and didn't take my medications, and I got scared straight when I saw MRI with multiple lesions, but no symptoms. I'm like, whoa, what's going on? So, I take my experiences and share that so that, my patients can, kind of understand that we're in this together, and, you have someone here that can hold your hand as your neurologist, but also hold your hand as your Black sister in MS.
Yeah, now that actually kind of ties into the question that we had for you guys next. So how do new patients of color respond to having a doctor who looks like them? If you wanted to answer that, Dr. Nolan, and then we
Yeah,
can
I can
do
kind of
Dr. Rosenthal and then Dr. Gyang.
segueing into that. It's always fascinating, regardless if it's an MS patient. I do see some general neurology, but a lot of times I'll have patients come in and they say, "We found your bio online, and we were surprised based on, I guess they don't know what race or if I'm a male or female based off of my name, but to see my picture online, they're come in really excited and just kind of wanting to come in with someone who may understand, some of the things that as, a Black woman or just a Black person in America, that we go through, and that things are a little bit, we kind of have that understanding about different things. And then, to take that for my MS patients and to bring on in my own perspectives and things of that nature. But I always enjoyed, and especially with like some of my older patients, and they're just like, "Oh, I'm so proud of you, girl." And, it's really, it's a good thing. And just, I think it's more, again, to be able to kind of understand, what are some of the things that we go through, as Black people.
Dr. Rosenthal?
Yeah, I agree. There's just a shared background, a shared culture that kind of gives you a level of comfort. We see that with racial and ethnic backgrounds, but I mean, it's pretty uniform with anything, right? If I see someone from Detroit, I'm from Detroit. I'm like, hey, we're from Detroit. It's a little, kind of shared thing there. Young people, women. So when you have someone that you can relate to in any way, it's refreshing. But I do think from a medical standpoint, it takes on a little bit of a different view just because of the history that Black people, Black women in particular, have kind of encountered. Generally speaking, not even just with MS, it provides a little bit of baseline trust maybe that wasn't there before. And I think that can be really helpful when you're already in a situation that's terrifying in the beginning. And so I do find that I feel good when I can maybe just provide that just by existing to patients.
Okay. Dr. Gyang?
Yeah, I mean, I think, we people always gravitate towards what they feel is more familiar. So I'm always happy to connect with people, however they want to if they identify with me in some way, and it makes them more comfortable. I'm always happy, to work with patients. And my other role as an educator is that I train other doctors to take care of patients with MS. And we're in a situation where not everybody is going to find somebody like them that is going to be a doctor to them. So the one thing I always try to, train, whether it's residents or my fellows, is that, you should be able to bond, connect, identify with any patient that walks through the door so that, they are able to build some kind of trust and, accept what you have to offer them. But, I find a lot of patients that, are really excited to know that, they can see something similar in me to them. Uh, but my ultimate, I wish we could spread it all the way around, but not everybody's gonna find somebody that they can identify with. And I don't like it when patients maybe don't reach out for the care that they need because they're just like, I don't get along, I don't think I'm gonna get along with any of these doctors. So I think the goal is to find somebody that you bond with. It may be similar to what you are. It may be somebody that's a little bit different, but don't be afraid to venture out and try to make a connection, even if you don't find somebody that looks just like you.
Right. Yeah, I think trust is another big issue within the Black community, especially, and in the healthcare system. We had those experiments that should remain nameless at this point, that have kind of given us nightmares about going to I mean, I don't think that anybody jumps up out of bed and says, hey, let's just go to the doctor today. Like, it's not an amusement park for for some people. But yeah, I do agree that it is a matter of finding something that you can relate to with that person, because this is someone you're pretty much putting your health in their hands partially. So you guys, it's a dance in a sense. It seems to be a shared experience because you get to know them better as a patient, they get to know you better, and then so it's good when it actually does work out. And obviously there's somebody for everybody. So thank you guys for pointing that out, that if it's not me, that it doesn't mean that it's nobody. There is someone for everybody within the healthcare system. So what do you see as different in Black individuals with multiple sclerosis and their experiences as opposed to their counterparts? I don't think we've started with you yet, Dr. Rosenthal, so you can answer first.
Yeah, I think from the very beginning, unfortunately, there are differences with how our patients of color, our Black patients are presenting. There's still a lot of bias. And so unfortunately, patients are being diagnosed later. And that's kind of a multifactorial issue in and of itself. Why are this group of patients being diagnosed later? Is it a problem with access? Is it a problem because we have a group of people who are scared to go to the doctor? Is it a problem because the doctors who are diagnosing these patients think that Black people don't get MS, and so they're kind of being misdiagnosed or undiagnosed? Is it because certain populations aren't being referred out to the specialists and comprehensive centers as early? So it's again, it's a multifactorial, kind of really complicated issue, and you could even really get into just even the systemic discrimination within the healthcare system of itself. But that's certainly a difference, and it's an important thing to highlight because we know how important it is to be diagnosed early for that long-term outcome. And then beyond that, even once diagnosed, we're seeing our Black patients just having a more troublesome disease course, having more frequent relapses, the recoveries between relapses not being as well. More optic nerve and spinal cord involvement. So the symptoms are behaving a little bit differently, faster progression to disability. And then the third thing I'll mention really is, and I think this is probably one of the more important ones, is potential differences in response to treatment. And I won't go too far into this because this may be a segue to another question, but we really depend heavily on our research to know how our medications behave in all groups of people. And when we don't have that, it really makes it hard for us to know how our medications are working for everybody. And there are certain treatments where we are seeing subtle differences, and we do need more information, which isn't to say that medications don't work in Black people. I'm not going there at all, but there may be certain nuances that need to be addressed and identified early on.
Dr. Gyang?
Yes, I mean, I agree with everything Dr. Rosenthal said, and there are definitely differences that have been identified in the way that MS presents in different demographic groups. And, you know, for a lot of it, we don't know how much of it is actually genetic, biologic, social, is it access to care? What exactly is driving some of the differences we see? I know Dr. Rosenthal mentioned a few things like, accelerated progression, more optic nerve involvement, disability rates are higher, in African American groups compared to a white individual. So those things have been identified and have been reported. I think a lot more research is needed to understand what is driving these differences. Is this a marker of a later diagnosis? Is this a marker, or is this something that's biologic? I don't know that is one thing. I think it's a combination of different things, but we definitely need more research and we definitely need more representation of all people in clinical trials, in clinical research. I'm sure we're going to talk a little bit about clinical research later, but we definitely need more information to understand this better, especially, with one other thing I'll talk about is, and I don't know if we're going to get to this, the incidence of MS, like the new uptake in MS, the recent studies are showing it's highest in Black women, so why is that change? Why is that different? It wasn't the case 20, 30, 40 years ago. So why are we seeing these differences? I think we definitely need more answers, and that comes through research.
Yes. Dr. Nolan, same question.
Yes, I agree again with both of them. And for me, it's even just kind of coming back to the base of just raising awareness of MS in the general population, especially in the Black community. I had no idea what MS was when I was diagnosed. The only reason I went to the hospital as quickly as I did, or to my eye doctor, is because I thought it was something going on with my eye, like I had a detached retina or something like that. But no idea that MS was even on the horizon, and I honestly had never even heard of it. And so we see this just in the general population. Why is it that everyone has heard of Alzheimer's, or heard of Parkinson's, different things like that, but unless someone has like a family member or a friend that they know, and we, until maybe more recently, are not seeing that as much in the Black community. Again, that's a whole other thing of, like what you were saying, Dr. Gang, is it because, that we're not getting diagnosed? Is it because, even within our community, as neurologists, not all neurologists are, comfortable with MS and diagnosing and treating it. So especially seeing it in the Black community, so patients can get pushed off, thinking that it's potentially something else going on with them, when it is a demyelinating condition or a condition like MS. So just raising awareness, that's kind of everywhere I go. I speak about how I'm passionate about that, and I want that to be, not because we're diagnosing everyone with MS. I don't want to diagnose you, but I want people to be familiar with it, so that we can advocate for ourselves, and say, well, hey, I was wondering, if when you go to your doctor, hey, I was wondering about this. Do you think that my symptoms could align with this? And if you don't feel like you're being heard, even taking a step back a little bit as far as for finding a doctor that you're comfortable with. It's okay to get second opinions, third opinions. If you don't feel like you're being heard, or that you, I guess, if you're not being heard and you want to have someone maybe take you a little bit more seriously, it's okay to, even after you've been diagnosed, switch doctors if you don't feel that your goals align with the goals of your neurologist. But I know I was all around the world with my response there, but let's get this the awareness of MS out into the general public.
Yeah, I agree with all of you. I've heard a few people say that when they were officially diagnosed, they were almost relieved because they say, oh, well, I mean, I've been having these symptoms for years and people have been like, oh, well, it's nothing. Some people I've heard it from both ends of the spectrum. Some people will say, oh, well, I kind of had blurry vision and then it'll go away and then I just won't pay attention to it. But then years later, I find out that I have a progressive form of MS. And then there are others who are like, okay, I feel like I'm losing my mind a little bit, but now somebody's actually giving me a name to this symptom or to the symptoms that I've been having. And I'm like, whew, like obviously I don't want it, but I'm just glad to know that it was not all in my head. Like my family members have told me that it is something that should not be swept under the rug. It needs to be treated as soon as possible. And the sooner you don't know, then the more problematic it can potentially become later on. So I do agree. And yes, the next question actually is about clinical trials and how people of color especially can get involved in research because it's such a low percentage of African Americans with MS who have actually participated. I think it's less than 5% from the research that I saw last year, but I don't know if it has changed since. Are there any general sources that you guys can actually share with the audience, anyone who is interested in participating? I guess we can start with Dr. Gyang.
Sure. I mean, and I love talking about clinical research, and I, do a lot of clinical trials here at OSU. So, you're absolutely right. There's an underrepresentation of, if you pick any minority population, whether it's African Americans, Hispanics, there's that underrepresentation that we see in clinical trials or clinical research in general. And why that is important is it affects what we call generalizability of the results. So I always give people this example. If we study an intervention or medication and we only study it in men, we can't come out and say, wow, this drug works and it works in everyone, right? We really don't know if it works in women because all the people in the trial were men. So we can't really generalize that result to everybody in the population. And I think it's same thing with any disorder, MS being one. If we're seeing differences in the way people are presenting with MS and maybe some differences in the way people are responding to some medications, we absolutely need a diverse population to study these medications in. And then we also need a diverse population to study about MS. How does MS happen? There's a lot of talk about EBV and MS and all these, how do people get MS? So regardless of what kind of research it is, whether it's a registry, a study, or it's a medication that we're trying to figure out if it's effective in MS, we need a very diverse population to be included in that research so that we know how that result or the results we get from the research, how it applies to everybody with MS. And sometimes, it is even more important to look at people that are underrepresented because you really want to identify. Sometimes I know there are studies that have looked at specific populations. We want to see how this specific population is going to do on this intervention, because no matter how good your clinical trial is, if it's a minority group, they will always be underrepresented in the study because in the population, these people are underrepresented. And so we definitely need more diverse populations in our research. There's a lot of ways to find out about clinical research. Talk to your neurologist, talk to your doctor. A lot of places have MS centers close by. A lot of clinical trials that are done in big MS centers. There are smaller MS centers or smaller groups that do clinical research as well. Clinicaltrials.gov usually would list the list of clinical trials that are going on. But, clinical trials are not the only type of research. I always tell my patients, you could be part of a registry. A registry means we're just collecting data from MS patients and observing them over time. That is a very low, it doesn't take a lot. You're not taking a drug, you're not, committing, a lot into it. We're just monitoring you over time and looking at your MRI and looking at how you do over time. So there's different types of research, with different levels of commitment, and we absolutely need all people represented, specifically people that have been historically underrepresented. We really need, more of these people so that we understand our interventions, we understand how the disease happens in different people groups.
Thank you for mentioning the different types of research, because I know that the opinions of certain people will not change because they're just very uncomfortable with being a part of clinical trials. So there is, like we said earlier, something for everybody, and it's a matter of finding that information. So thank you for emphasizing that. How about Dr. Nolan and then Dr. Rosenthal?
I don't know if I have anything else to add. That was excellent. One thing, and I kind of joke about this sometimes when I say it, but sometimes you can approach when considering if you want to participate in any type of research, especially if you want to go into kind of clinical trials or things of that nature, you can sometimes approach it selfishly. Some of the trials, you can get free MRIs. There are other ways to get free MRIs without having to do research, but that's one route to go, a way to get MRIs, or even to get free drug. It's not going to be kind of maybe a long-term thing, but for however long you're participating in the trial, there are different things that you can also get from it, in addition to giving the MS community more data with diversity in MS. And there was one other thing that I wanted to say, but I can't think of it now. Maybe after Dr. Rosenthal talks, I'll think of it.
No worries.
So I would add that this really, I think, is important, highlights the importance of having a neurologist that kind of gets you, having that relationship, because for you as a patient to really trust your doctor, because that's who can kind of be like that, almost that gateway into research potentially, because they're going to have a good idea of what's good for you. And hopefully you would have that trust that they would not present something to you that would do more harm than good. We do a lot of research where I'm at, and I have a lot of patients that ask me about studies that maybe even just seen through like advertisements, and I'm like, oh no, that's not a good one for you. Or conversely, there are other studies where, and I know that clinical trials in and of itself, that sounds so scary, but by the time you get to like a phase 3 clinical trial, that medication has already been through so much testing. And then depending on what type of MS you have and what you're dealing with and what maybe you've already kind of burned through in terms of other drugs, the benefits really do outweigh the risks. And at that point, we're really talking about risks in terms of efficacy, but when you've already tried other options for certain patients, especially those with progressive forms of MS, clinical trials are so great. I love clinical trials for progressive MS because I'm able to provide patients with options, when there are none for a lot of people. And the other thing I'll say too is the phase 4 clinical trials. These are awesome because these are medications that have actually already been FDA approved, and you're able to now participate in research to answer these kind of secondary questions, right? How does this drug perform in, young women of childbearing age, or how, and little nuanced things where now, you're taking a medicine that other people are having to go through their insurance for, go through those sorts of hurdles, and you're able to be a part of this study, contribute to research, and really get a whole lot of extra attention from a medical standpoint. And so there's just so many types of research. I saw one of the comments that mentioned studies for people, I can't remember the age, maybe over 65. And just like she said before, you know, there's all these different types of research. True, a lot of these clinical trials, when you're talking about medications, they do have a cutoff at age 55 or 65, but there are exercise studies and symptom management studies. I mean, there's so much research that you could participate in that isn't someone trying to give you, you know, an MS drug. So there really is a lot of options, and talking with your doctor, your neurologist, can hopefully kind of give you some idea of what you may be capable of participating in.
Thank you all for sharing that. We are going to jump into the questions from the attendees now. Some are general, but from here, I'm not necessarily going to ask any particular order. It's if you have an answer for it, just unmute and take it away. So we'll start with Edna in Q&A. She asks, how should spasticity be treated?
I mean, I could take a stab at that. So, I mean, I will start with, okay, what is spasticity? So a lot of patients with MS, it's not specific to MS, but most patients that have issues with the brain or the spinal cord have what we call spasticity. Basically, that's stiffness or resistance to, you know, the flexible movement of your muscles. And that typically comes because there's a scar or there's some kind of injury in the brain or the spinal cord. There are different ways to treat spasticity. You know, I always start with non-medication or non-pharmacologic options: exercise, stretching, physical therapy, movement. It typically gets worse when you're not moving a lot. So I always have my patients start with that. And then there are medications that can be used to relieve some of that tension or even spasms. Some people have these spasms that they have in their muscles. It could be in the legs, the arms, or tightness where they can't really relax or release the muscles. So medication examples, and this is something you have to discuss with your neurologist, things like baclofen, tizanidine can be effective, you know, depending on, you know, how bad the spasticity is. These are medications that can be used. Some of them have side effects. Some of them can be a little sedating, or, you know, can cause a little bit more weakness if there's a significant weakness in a limb. There are other things that can be done where the spasticity is very severe. So baclofen pumps, you know, some patients that have very severe spasticity, we actually put a pump that delivers very little amounts of baclofen into the spinal fluid. And that way we're getting enough to, you know, the specific places that we need, you know, the medication. And then there are other cases that can be treated with Botox. If, you know, you have a small muscle group that is tight or that's not, you know, relaxing, we could do Botox every few months. So that's kind of the general approach, but I always emphasize on movement, physical therapy, stretching. You know, you really need to keep that muscle moving. You could do medications, you know, if you need to do medications, being aware that some of these medications have side effects. And then there are interventions like, you know, the baclofen pump or injections, Botox injections, if it's much more severe, or you have a limb that's just contracted and you can't really release it at all. So that's a little bit about spasticity. I hope that was helpful.
Sure. I'm looking in the chat and I see someone named Renee say that her daughter was misdiagnosed. Initially, she was diagnosed with lupus, and that is hereditary from what I'm seeing from her first comment. However, she ended up being diagnosed again, but this time with multiple sclerosis. And she's wanting to know how there is confusion between the two. Yeah.
I'll take that one. So both are autoimmune conditions, right? And it can be confusing in that it could be one or the other. And this is just speaking generally, or it could be both. And we know that when you have one autoimmune condition, you are going to be at risk for others. And so we have a lot of patients with multiple autoimmune conditions, MS and other stuff. MS is unique in that it's really localized to your central nervous system, so your optic nerves, brain, and spinal cord, whereas other autoimmune conditions like, lupus, rheumatoid arthritis, that sort of thing kind of can affect the whole body, including the brain. And so for us, sometimes as neurologists, it can be hard when there's more than one thing going on, because MS can cause brain lesions, but so can lupus. And so it is hard to differentiate if it's one or the other or both. But sometimes it is somewhat of a moot point at the end of the day. If you know somebody has an autoimmune inflammatory condition that's, impacting this or that body part, you want to treat it with the appropriate therapies. What I'm finding the longer I've been practicing medicine is that a lot of our labels change. And at the end of the day, what we want to do is control the medical condition. So same thing with lupus, MS, RA, psoriasis. You want to kind of halt that disease as best you can, and you accomplish that through our immune therapies.
Thank you for that. In the Q&A, Denicia, she asks if anyone is able to give me their views on the holistic treatment versus medicine.
Yes, I can jump into this one. We kind of look at it, or I look at it from kind of two different standpoints. So when we're talking about modifying disease activity when it comes to MS, the disease modifying therapies, the different medications that we have, those are the only things that we have seen in clinical trials that can help to address the inflammation that we can see with MS, or the overall progression of MS. When it comes to symptomatic management, this is where I feel that holistic medicine has a little bit more of a role with managing things like spasticity, or even mental health, with other things like if we're treating fatigue, there, are other more holistic things that can play a role there. But that's kind of like a quick thing of how I approach it. So I do think with MS, there is a role for medications when it comes to disease modifying therapy, but there's also that role for holistic or more natural medications, primarily, in my opinion, when it comes to symptom management.
And I'd add, maybe not to even add like the traditional versus holistic medicine, because it really shouldn't be this or that. It's trying to be incorporating them together to have the best outcome.
Yes, thank you. Edna has dropped 2 questions into the Q&A. She wants to know the best way to treat fatigue and what your opinions are on FES and bias. I hope I'm pronouncing those correctly.
Right. So fatigue is complicated for a lot of people. We look at fatigue. So fatigue is going to be what the most common MS symptom that people complain of. And I think it's because it is so complicated when you look at all the different MS symptoms that can contribute to fatigue. So if you're, waking up a lot during the night, your sleep's interrupted. And then if you just look at staying on that sleep subject, we know that sleep disorders are more common in MS patients. Pain, spasticity, sometimes interrupting sleep. Mood disorders are more common in MS as well. And so that can contribute to energy levels as well. And so when we're looking at fatigue and how to treat it, the first thing we try to do is look at what's causing the fatigue and trying to address any of those underlying issues first to try to promote a more effective sleep during the night. Or during the day, depends what your life is looking like. We look at the cumulative sleep. Beyond that, and addressing those symptoms, sometimes, the kind of non-medication ways we want are to, increase activity, exercise, taking short little naps during the day for those people who are able to do that. And not everyone's a napper, and I totally get it. Because if you're like me and you go to sleep, that's it, you're not getting back up. Also, there are certain kind of supplements that people may try, and making sure that there's not a deficiency that could be contributing to fatigue levels, making sure that's addressed, eating a healthy diet. After that, there are certain medications we use to kind of promote wakefulness, but of course, those are going to come with other potential side effects, because then you may put yourself in a situation where there's difficulty falling asleep again. And so that's what we kind of use more of a last resort, but they are there and a lot of people need them. But again, it's kind of starting from the low-hanging fruit in terms of what could be causing the fatigue, and then going from there. And then what the other part of the question was for BINS and the electrical stimulation devices. Those devices are usually really expensive. And some people use them when they get them, and some people it stays in their closet. And so for that reason, I think it's really important to get in with a good physical therapist that knows how to use them and can do an adequate trial, so that you as the patient can see if it works well for you, if you could tolerate it, if the electrical stimulation is uncomfortable or it hurts, you're not going to want to use it. So really getting that good evaluation. And oftentimes it's not that, it might be secondary or separate, I should say, from the distributors, to see how that works for you. And if so, then there are a lot of options to help pay for it, because it can be expensive, but at least then you're not going through all of this stuff just to get this piece of equipment that you end up not using because it didn't work out well for you.
Lynette.
To add an additional thing with the fatigue, I know it can be very hard to describe any symptoms that you have, but with fatigue, the way that we approach it and treat it might be a little bit different based on the type of fatigue that you have. So there's kind of more of the fatigue where you just kind of feel like what Dr. Rosenthal was saying, where you just feel sleepy and you just want to nap. And just kind of rest all of the time. But then there's also a type of fatigue that we call like motor fatigue, where it's more of your body physically kind of feeling tired. Your walking can be exhausting for you and your muscles just feel kind of weak. And we might treat that in a different way than we would treat kind of excessive daytime sleepiness. So trying to find a way to be able to explain your fatigue a little bit better, and any other symptom that can be helpful with us when it comes to figuring out how to best approach working up and treating your symptoms.
Thank you. Lynette in the chat says, I want to do clinical trials, but what if I'm holding steady and then receive a placebo and then decline?
So, go ahead.
Okay, yeah, I mean, I could take that, and maybe Dr. Rosenthal could add on what I say. So the concern is, you want to do a clinical trial, but you're concerned about being on a placebo. I think, whatever clinical trials are available, you want to sit down with your doctor and get as much information as you can about it. A lot of the clinical trials right now with relapsing MS typically do not involve a placebo arm. And the reason is because there's so many drugs for relapsing MS. Like, it's not very ethical to put somebody on a placebo for about a couple years or 3 years if there is a drug. I mean, right now there's over 20 drugs for MS. Most of the trials in relapsing MS do not include placebo. So that's one thing. I have seen some trials in progressive MS that include a placebo. Right now, there's only one drug for primary progressive MS. For secondary progressive MS that's not active, we really don't have an FDA-approved treatment for that. So I think there is some understanding that a placebo may be reasonable in that group. And I've enrolled patients that are just on nothing, are not on any drug, and it's like, okay, I'm just going to do this clinical trial. There could be a chance about the placebo or the real drug, but they were not on a drug to start with, so it doesn't really make a difference. So regardless of the clinical trial you're going into, have a very, very thorough discussion with your doctor, with the doctor that's the PI or the person that's overseeing that clinical trial, and you weigh the risks and the benefits of that trial for yourself. If you're on a very good MS treatment and your MS is very well controlled, it may not make sense to jump into a clinical trial where you may be mixing things up and putting yourself at risk to relapse. But if you're that person that maybe has progressive MS, you're not on a treatment, or you're newly diagnosed, or you're in between treatments, maybe the treatment you're on isn't working for you, you're looking for a change, then it may be something to talk about. I have a lot of clinical trials will want you to have at least some relapses recently. So they're not looking for that patient that has been stable for 5 years and has not had a relapse. So most trials would want you to have some degree of, your MS is not well controlled before you get into that clinical trial, and talk very extensively. If you do not understand what you're getting into, or you're not getting your questions answered by whoever is running the trial, that it may not be the best thing for you to do. But you really want to understand, what am I getting? What are the chances of getting the intervention drug or a control? And is that control a placebo, or is that control an active control where you're getting another drug that is approved for MS, but is different from the drug that is being studied? So I think just get as much information as you can and make the decision for yourself, right? If that decision doesn't serve you, if there is any issue with you being on that trial, then you really want to weigh the pros and the cons and talk with your doctors, ask as many questions as you want. And remember, if you're in a clinical trial and any issues come up, you can stop. We don't like it when people stop, but you're not like obligated to be in it till the end. You could just, talk to your doctor, and if you're not comfortable at any point being in that trial, you can stop. But before you get into it, ask as many questions, make sure that this is something that would work for you, and it's not putting you at jeopardy in terms of your MS.
Thank you. I have a few general questions in the Q&A. Two people ask if there is a national registry or directory for Black neurologists and MS specialists, and if so, what are they?
I'm not sure, for Black neurologists, I'm not sure who's keeping a list of that. I know there are certain organizations that are trying to. We Are Ill is trying to keep a list. That's the only one coming to mind. Unfortunately, I'm trying to think if there's any. Jakai, did you have?
Just We Are Ill. I don't know of any other one.
Okay.
And Dr. Nolan, there is a question specifically for you here. It says, was it your diagnosis that fueled your passion and purpose to become a specialist? I'm assuming this person joined later, but I know you touched on it a little bit earlier on.
Yes, so not why I went into neurology. I was already interested in neurology, but definitely why I went into MS and why I had that particular interest in MS. So it was kind of from like a selfish standpoint. I realized throughout my training that some of the care that I had actually received before was maybe not the best care that I could have received, as someone living with MS, but I had no idea. I didn't know that, I probably should be getting an MRI on more than just only when I have new symptoms. So it was like things like that I wanted to make sure that I knew the best of, not only for, mainly for myself. That was kind of my original, interest of kind of jumping into the field. But, just also knowing that eventually when I got comfortable, and as I'm comfortable now, knowing that I would be able to bring that perspective as both, the patient and the doctor, and the role that I could play, that was something that pushed me to go further with it. And then to add in, I know there's a question about a registry for Black people with MS. I saw that someone posted it. There's a National African American MS registry, and I can maybe post it again.
I'll do that. Don't worry about it.
let's see. I'm just copying what Casey Menace posted. Or maybe Casey, can you repost it yourself? It's not letting me.
Absolutely.
Oh, hi. I'm sorry. She's with us, guys. Thank you.
And it looks like we have a few, or not a few, but quite a few their questions. And I know we are approaching the hour. Are you guys good on time, or do you need to leave at 7:30?
I am good.
Okay, awesome. So there's another question from Denisha. I'm pretty sure that's how you say it. If I'm saying it wrong, please forgive me. But she says, I'm having a hard time getting approved from disability. Do you have any advice on what I can do to get approved?
Disability is so rough. It's harder than it should be. And unfortunately, I think a lot of the decision making is factors in things that are not unique to multiple sclerosis. There are certain support systems through like National MS Society or other areas that can try to walk through that in terms of how to go ahead with that process. Depending on where you're getting your care from, there may be social workers that can help facilitate that as well, because there's a lot of back and forth with documentation. But it's rare that people, generally speaking, are getting approved the first time around. Again, it's incredibly difficult, way harder than it should be. I almost think that it's like an exercise in just seeing if you have the patience to keep applying for it when you need it, because they make it so difficult. But definitely, you know, I would say to keep at it. Talk with somebody who can help with getting the information that they need in order to make that decision. Sometimes there is some ancillary testing that can really help, whether it be like cognitive testing, that sort of thing. Certain other specialists getting their input in can really make that process go make a really hard process slightly less hard.
And someone asks, are there homeopathic remedies that can help with MS treatment?
You know, I always try to, whenever I'm talking to patients about treating MS, I always try to differentiate treating the disease, you know, modifying the course of the disease to prevent new lesions, from treating the symptoms of MS. Those are two completely different things. Right now, I'm not aware of any homeopathic remedies that have been proven to reduce the inflammation or, you know, new areas of inflammation that we see in the brain. So, you know, I always encourage people that are still building new lesions and still having a lot of relapses. The only evidence that we have that, you know, of medications that can prevent that are the disease modifying treatments. However, if you're talking about symptomatic management, you know, you're tired, you have pain, you have spasticity, you know, there we could do a lot of different things. You know, we always start with, you know, non-pharmacologic approaches, physical therapy, you know, all sorts of things. And then, you know, there are all sorts of things that could be helpful to help relieve symptoms. One question we get asked a lot is, you know, medical marijuana, you know, just things that are not traditional, like, you know, medication wise. And there is evidence on some of these things. You know, medical marijuana has been studied for some symptomatic management in MS. Some states have liberalized the use of that, and you could get that, you know, at specific dispensaries. You know, I can't really think of anything that comes off the top of my head, but for symptomatic management, I think there's a lot of different options of what to do. But in general, if you still have new inflammation in the brain, meaning you're still building up these new lesions, I typically would recommend that you be on one of the disease-modifying drugs, meaning one of the traditional MS drugs that can help reduce the impact of inflammation in the brain. But you could do a host of different things for symptomatic management. That is more optional, and you could figure out if there's any things that could help. I don't know, maybe one of the other doctors have other special remedies that they've heard about that may be helpful.
No other special remedies, but to add onto the importance of being on a disease modifying treatment or therapy is the fact, and to kind of explain one of the reasons of why we like to image the brain, you know, at least like once a year for majority of patients, is the fact that you can have continued lesions or areas of inflammation in the brain that build up, but don't necessarily cause you to have symptoms. But that doesn't mean that because you don't have symptoms now, it doesn't mean that you may not develop symptoms from that area later on down the road. So everyone, as we age, our brain shrinks. But in those with MS, not on any, when you're not on any kind of medication, the shrinkage of the brain is a little bit more rapid. So if you have an area that is not functioning properly because there's a lesion there, or like scar tissue or something there, as the area around that lesion starts to shrink, then your brain might not be able to compensate as much for it. So 20, 30, 40 years down the road, you may start to show more symptoms from that lesion that came up 20, 30 years ago. So I often like to explain to my patients that not only am I treating current day you, but I'm treating you in 20, 30 years. One important reason why I also like to go over MRIs with my patients. So if your neurologist isn't showing you your MRIs, maybe you can request that that they're going over that with you. Again, it just kind of drives things home a little bit more and helps you understand your condition a little bit more when you're physically able to see things. Not necessarily asking them to count every single lesion that you have, but again, just to understand a little bit more about your health there. So again, the importance of disease modifying therapy, and to bring it back to me, don't be like me where you're like, oh, I don't have any symptoms, I'm okay, I don't need to take my medicine. And then again, you get that MRI, you have like 6 new lesions, you're like, whoa, what's going on here? So things to consider there for you.
Thank you. Carmen says that she was diagnosed last August, and she says her problem is vertigo, and she is wanting to know how she can ease that.
Vertigo, just generally speaking, is really complicated because it can originate from different parts of not even just your central nervous system. You know, there's inner ear things that can happen as well that can contribute to or worsen it. So, you know, that's something that I would definitely recommend talking with your neurologist about. Sometimes referrals to physical therapists that specialize in vestibular rehab can be really helpful at trying to kind of retrain the brain to acknowledge the vestibular input a little bit more correctly. It's not perfect, but it can certainly help. There are certain medications that aren't that great from a symptomatic management for treating vertigo. But I would say just getting that specialized vestibular kind of examination and potentially even seeing an ENT if need be to make sure there's nothing else contributing to it can be helpful.
And there's another question about vision. Jasmine says she has optic neuritis, and she often sees an array of overlapped colors, and she just wants to know what she can do as far as recommendations from you guys.
I mean, I could try to answer that. So generally optic neuritis, at the time that it's active, you know, patients have blurry vision and pain in the eye, especially pain with eye movements. Typically that would happen when there is an active lesion or there's active inflammation in the optic nerve. Typically that would last for, you know, a few days, a few weeks, depending on, you know, did you get steroids and other factors. Most often those symptoms get better. However, just like with MS, with other lesions in different parts of the central nervous system, there's a scar that's left behind. And I always tell my patients at any time, these scars could act up, right? Like people can come up with numbness, tingling, weakness. Generally, things like stress, high temperatures, you have another illness like a fever, anything that could raise your body temperature or any kind of stressor could more likely elicit some of these symptoms. In terms of visual changes, I'm not aware of any specific medications or pharmacologic therapies that could alleviate that. But, basically we have to make sure, let's say you're not having a urinary tract infection, or, if you're exposed to the heat, you want to cool yourself down. We want to make sure there isn't anything that's triggering a worsening of those symptoms. Over time, most people learn to adapt to the symptoms that they have at baseline. But in general, if you have an active lesion, like optic neuritis, we would typically treat you with steroids. But based on that scar that's left behind, you may have on and off intermittent symptoms that come and go, in that specific part of your nervous system. And it's a matter of figuring out if something triggered it that we could treat. If it's an infection, we treat that infection, or if there's other things that could trigger that symptom to come on that we could change.
Mary asks, should Botox be tried before a baclofen pump?
That it depends. Everyone's different. It depends on where the spasticity is, how bad it is. If someone's still ambulatory or walking versus maybe not. So it varies for everyone. I will say usually Botox is used before a baclofen pump just because it's less invasive. But it really varies, and it kind of really highlights getting that good exam to see what would be the best treatment for you as an individual.
I'm kind of jumping around here, but I see a question in the chat. Someone asks, is there a correlation between multiple sclerosis and childhood trauma? That's a first. I've never heard that question before.
I haven't heard any direct evidence that has linked MS and childhood trauma. I know there's a lot of research on ACEs, adverse childhood experiences, and I've read some articles that have linked a high ACE score. So there's a way to calculate, an ACE score to determine how much childhood trauma you've had or adverse, events you've had in your childhood. There's some studies that have looked at that to look at inflammatory profiles. And, I know of at least one study that has shown there's a pro-inflammatory profile associated with a high ACE score. But I'm not aware of any research that has shown a direct correlation between having a high ACE score or having a lot of childhood traumatic experiences directly with, having MS or having any other autoimmune diseases. It's not an area of my interest, so I don't know a lot about that, but I'm not aware of any research that has shown any direct correlation between that.
Pam says that she was diagnosed in 2009, and since she hasn't had any new symptoms, she says that she's on baclofen and she takes it as needed, typically if she has issues during her cycle. And she says, would I be considered relapsing or clinically isolated? Or how does she know the difference, yes, between CIS and MS?
So again, that's kind of without, having all the information, just generally speaking, and clinically isolated syndrome versus MS. So with a clinically definite diagnosis of MS, we've been able to kind of prove to ourselves that there has been inflammation to your central nervous system over time. And we do that by looking at the lesions on the MRI. Sometimes we can see that they're active or lighting up with the gadolinium contrast that they give you, versus maybe those that aren't. And that tells us that maybe lesions occurred at different times. Sometimes we accomplish that with symptoms if there's been, more than one symptom over time. And then the one kind of changeable factor over time, if you look at the different iterations of the MS criteria, is the role of the spinal fluid. So sometimes the lumbar puncture will give us that extra criteria to tell us if this was something that has or that we expect to recur over time. If we're seeing that they're making additional proteins within the spinal fluid, that would go ahead as well. And so it's a bunch of different criteria we put together to make that diagnosis.
Doctors, can you guys open the Q&A window if you haven't already? If you see the comment on the top from Marsha, what is that long L word? And does it work for spasticity? I don't have my glasses on, so I'm like, I don't know what I'm seeing. And usually I'll actually take time to sound things out, but I don't have my glasses.
So it's levetiracetam. That's a seizure medication called Keppra. I mean, the Keppra name is much easier than the long name. So the question is, does levetiracetam or Keppra, does that work for spasticity? It's not a go-to drug for spasticity. Some of the drugs that I use for spasticity are seizure drugs, but this specific one is not the go-to drug. However, I always want to delineate the different types of spasticity patients have. There are patients that have what we call tonic spasms, where it's kind of like a zing of electricity, that like a shock of spasticity that happens. It lasts for a few seconds and then it gets better. Typically, we treat that with seizure medications like Tegretol or Trileptal. I've had a few patients that have tried Keppra for that. It's not the go-to drug, but there are other anti-epileptic medications that can be tried for spasticity. If we're thinking of the more common type of spasticity where it's tightness, you're having trouble with just relaxing the muscles, or your leg is not flexing enough and you're having trouble walking, baclofen, tizanidine are more common types of medications that we use. If you have the other type that's more of the tonic spasms, there are some anti-epileptics that can be a little bit more helpful. But Keppra or levetiracetam is not a common drug, a common go-to drug that we would use for that. So talk to your doctor and explore the different options.
Kim in Q&A says that she took 2 rounds of Luntrata and has blurry vision off and on. And she says that when she complains about eye issues, the doctors always say, well, you're not inflamed. So any suggestions on what she should do from here?
I feel like that's a common theme that we see with MS. So one thing to note, that not every symptom that you have is going to be related to MS. It could be related to other things. In this particular situation, I would definitely say speak with your neurologist to make sure that, so maybe their eye doctor has ruled out inflammation from an ocular standpoint, but it could be possible that something else is going on. And so maybe getting an MRI of the brain or something like that to just gather a little bit more information might be a good step to go. So speaking with your neurologist about that could be helpful.
It looks like someone is asking what lesions are. They say they know from a spiritual stance, but they want to know what it is medically, and they have an updated 3 MRIs coming up.
I know we use that word lesions a lot. We say lesions, scars, white spots, and they really all mean the same thing. But when we say lesions, when you talk about just multiple sclerosis and you get these areas of inflammation, that inflammation only stays really inflamed for about a month, rarely may go out to maybe 6 or 8 weeks. But when that inflammation resolves, it always leaves behind a scar. So if you think about if you were to fall down and scrape your leg real bad, it's going to be kind of red and angry, and then it'll scab over, and then it may leave this kind of a scar where it's damaged skin. And that's kind of what's happening in the brain. That scar is there. It's no longer inflamed or hurt or active, but it's a part of the brain now that's not a normal brain anymore. And that scar is going to stay there forever. You know, sometimes we do even see lesions that maybe look a little different from scan to scan, and depending on where they are, maybe they fade a little bit from the MRI, but they're still there, even if the MRI shows it a little differently. But that's what we mean by lesions. It's those scars, those areas of where that prior inflammation was, and now it's showing that area of brain that's no longer normal.
A question from someone asking how they can treat insomnia.
That could be a tough one, and there's a lot of different reasons for patients not having trouble with sleep. So I think first you just want to try to figure out, what the problem is. A lot of times things like anxiety, depression, mood symptoms can affect your sleep. So we want to make sure that, if there is anxiety, depression, we're taking good care of that, using a therapist, you're on a medication, or, some kind of treatment for that. Sleep apnea is a lot more common in patients with MS. And so we always want to screen for sleep apnea where, you're having trouble breathing or maintaining your airway while you're sleeping. And so it's not uncommon for us to send our patients to a sleep specialist for investigation to just see how well you sleep at night. And then there are just cases where we don't have a good reason, right? And you don't have sleep apnea, your anxiety, depression is well controlled, but you're still having trouble sleeping. There are things that we do that can affect our sleep. We have a sleep hygiene protocol that, we advise to our patients. So just doing simple things like avoiding caffeinated drinks towards the end of the day, avoiding any kind of high rigorous activity at the end of the day, doing routines or things that just help your mind and your body to calm down at the end of the day. And there are times that you may need to do a medication to help you fall asleep. That's typically the last resort. We don't want to jump to starting a medication as soon as, you're having some kind of issue. I always let that be the last resort. And, the one thing I say is always try not to do something that is that you can get dependent on. We always try to avoid things like that, because the last thing you want is to be dependent on a medication and you can't fall asleep if you don't have that medication on. So there are different things. There are some of the medications we use for pain or for, spasticity that can be a little bit sedating. And sometimes we just up the dose at the end of the day so that, it helps you calm down and it helps you go to sleep. So there's a lot of different ways to handle it, but it's always making sure that, we have a good reason why you're not falling asleep. If we don't have, sleep apnea or anything else that's going on, we could optimize some of the medication side effects that are sedating to do more of that towards the end of the day to help with sleep. And, there are other medications that could be used specifically for sleep, but I always recommend against doing a medication that you can become hooked on or dependent on, because then you're just not going to be able to sleep without it. And you want to avoid treating MS. I always tell my patients it's a marathon. It's not a sprint, right? If you have a little short sprint of, you're on steroids and you need to do something to help you sleep, yes, we could do something to just help you sleep, get through that. But the chronic symptoms, these are symptoms that you have over a long time. We want to avoid medications that could be potentially addicting, because you don't want to be taking that for the rest of your life.
Awesome. We are actually about an hour, 15-ish minutes in. I know that we all have schedules and things of that nature, and there are still so many questions coming in. I don't want to give anybody the shaft, but I also know that you guys are the ones answering the questions, not me. So how much more time can you stick around for the attendees?
I could do like 5 more minutes.
Okay, got it. So with that, I'm going to first of all minimize my screen because I don't know why it's so large. And then I'm going to see if the people who have their hands raised have either had their question answered or not. Margaret, can you unmute and you can ask your question if you're still there? I think you should have the ability now. We can't hear you, girl. So I think I'm going to go back to the Q&A. Wait, hold on a minute. Edna, are you there? If so, please.
I am.
Awesome. Do you have a question for the doctors?
My question was, I have PPMS, and I got my last infusion in February, and that was because I was having insurance issues. So I was scheduled to get it in January, but even then, I was having a real rough time. I'm on Ocrevus. And I know they recommend I do get my infusions every 6 months. I want to know, is it possible for me to get my infusions more often than that? Do they recommend it? Or should I look at maybe another drug? Or I don't know.
So unfortunately with PPMS, we have so little options, right? So Ocrevus is the only FDA approved option. I always, for my patients with PPMS or inactive secondary progressive MS who aren't doing well with Ocrevus, we kind of look at the different clinical trials that are out there as a potential alternative for something else. Not that that's appropriate for you. That's something I would definitely say discuss with your doctor. But in terms of your question about more frequent Ocrevus, it really varies. I sometimes insurance won't pay for it more frequently. Sometimes they will. Looking at your blood work though, and so that's why it's a very individual decision. Some people do have their B cells, which is how Ocrevus works, kind of come back a little early. We do see that happens actually more in the Black population. The B cells are coming back a bit earlier, but when that does happen, it just kind of shows your body needs it a little bit more frequently. And so we'll do it for that reason. Sometimes people just feel it wearing off a little early. And then when that happens consistently, we sometimes do that, but that is provided it's safe. And we determine if it's safe based on a lot of different factors. Part of that is what the rest of your blood work looks like, because we don't want the Ocrevus to over impact your immune system to the point where now you're having difficulty fighting off frequent infections and that sort of thing.
Okay.
Thank you, Edna. The next person who has their hand raised is Jane. If you are there, Jane, please unmute and ask away. Jane. Okay, I'm gonna move on to Patricia. Are you there? If you are, please unmute. Patricia. It looks like she's not muted, but she's not speaking either. Okay, so next, Catherine.
Oh, Jack is here. I'm sorry. Can you hear me?
Yes, ma'am.
Okay, my question was, like, I noticed that when you all mentioned, the lesions or scars, well, I had several MRIs of the brain, and I didn't have any lesions in my brain. All of mine were on my thoracic and cervical spine. And I was wondering if that could be included in the protocol for diagnosing MS, because I was misdiagnosed for years because everyone was looking for lesions in the brain and it wasn't in. And I could have, received treatment a lot earlier, at least 6 years earlier than I did. And it wouldn't, I don't think it would have progressed to primary progressive as fast if I had been able to be diagnosed earlier.
Yeah, I mean, I could try to answer that. So in general, most MS patients have lesions in both the brain and the spinal cord. To meet the diagnostic criteria, we have to make sure there are lesions in different parts of the nervous system. So it's a little unusual to just have them in the spinal cord, but I have actually had patients where, they have multiple lesions in the spinal cord that look just like MS. They have those inflammatory proteins in the spinal fluid, but they've just never had that brain MRI finding that is consistent with MS. The one thing we always want to make sure is that this is not a disorder that's mimicking MS, meaning it's a different disorder presenting itself to be like MS. So there are other disorders that will primarily affect the spinal cord and generally would not affect the brain. But there are patients that I have taken care of that have multiple attacks, and all the attacks have to do with the spinal cord. And people handle this in different ways. In general, the way that I handle this is, yes, you need to be started on some kind of medications to prevent those attacks from happening over and over again. In general, we try to do a medication that can cross different paths. So something that's not specific just for MS, but is applicable to MS and maybe some cousins of MS that may present very similar to MS, but maybe are not MS. And reason being, from a diagnostic standpoint, majority of patients have brain lesions. It's rare to just have spinal cord lesions. So understandably, sometimes there's a delay in the diagnosis because we're not seeing those brain lesions. But treatments should still be given. In general, we try to be a little bit more careful with picking the specific treatment for the case that this may not exactly be MS. We want to do a treatment that would cover, MS and maybe other things that are similar to MS that may not be exactly MS, but different providers will have different ways of handling this. Technically, if we're looking at the textbook criteria, if you only have spinal cord lesions, if you look at the textbook, you may not meet that criteria. But if you're having multiple attacks and you're having multiple hits to the spinal cord, you absolutely need to be treated. So that would be the way that I would handle. And you may get variations. Different people may handle it in different ways. Yeah.
Okay. Because I had all of the symptoms, but I mean, the lesions, just didn't show up. I had the symptoms and the falling and balance issues and pain, but they just said I didn't have it, so for a long time. So that was my case, is the misdiagnosis of it.
Yeah, that's it seems like it's quite common. Like even from someone that I know personally, actually it was my prom date's mom, like years ago. She had been in the hospital off and on, and they told her that she was having a series of strokes. And then, like maybe 5 years after these episodes, she said, well, apparently I wasn't having strokes at all, but it was multiple sclerosis. And so it's just very strange how they can just come up and like the young lady who was misdiagnosed with lupus earlier that we had talked about, or you guys had answered her questions. I don't know why it's a journey for some before they're actually officially diagnosed. Some get the runaround a little bit, some are diagnosed right away, but I think it comes down to, again, MS not being a one size fits all. So certain treatment options that would work for this group of patients would not work for the other. I've never heard a diagnosis story that was the same. Like, this is what I was kind of sharing with the panelists from 2 weeks ago. Everybody's story is different. And it
Yeah,
really
one
is
thing I would add, I'm sorry.
individualism. Go ahead.
The one thing I would add is getting a second opinion. Don't ever be shy about getting another opinion from another doctor if, and even if your doctor seems great, and you just have more questions, always get that second opinion just to hear what somebody else has to say. Because there are certain things that are in the gray zone. There are certain things that are obvious and, you meet that textbook criteria. And then there's certain things that are very gray, and one person may see it one way and another person may see it a slightly different way. But in general, if you're having recurrent episodes where you're having these attacks and we can actually see them on an MRI, then, it's a matter of what we call it. You need to be on some kind of treatment, and you could get a second opinion if, if you're not making any headway where you are.
And also neurology is an ever-growing field, and we're learning more and more. 20, 30 years ago, there some of the things that we know now that can look like MS, but we now know that, within like the last 10 years, that is actually not MS, and we're finding new antibodies, things for different conditions. So the field grows, and if things don't necessarily fit, I think Dr. Rosenthal spoke about this a little bit earlier, of where there are we kind of overlap medications for different conditions, and sometimes finding a medication that can treat this condition, but if it doesn't end up being this, it won't harm you if it's some other autoimmune condition, where we would still be able to kind of get the overall protection of the nervous system that we would need. So again, yeah, there are different ways around, and absolutely I agree, get that second opinion, and make sure that you're comfortable, and that whoever diagnosed you, that they're comfortable with your diagnosis too.
Yes, that is all the time that we have for now. I thank you, ladies, so much for taking on as many questions as you have, and for staying over. We appreciate it so much, and we hope that we can have you all again soon, not just for Black History Month, but for any time of year. Thank you guys for what you do individually and collectively. And this was awesome. And I see a lot of thank yous popping up just now and a few minutes before. So this is going to be something that will definitely help the Black MS community and the MS community as a whole, I do feel like. So if you guys have missed any part of this teleconference, it will be on our YouTube channel, Multiple Sclerosis Foundation, within a week. But you don't have to necessarily wait for that upload, because we are live streaming from our Facebook page as well. So when we close out the webinar here on Zoom, it will process, and then within a few minutes, or maybe even a few seconds, you'll be able to see the entire recording from start to finish, and then you guys can just watch it from there. Our next conference, if I'm not mistaken, is with Dr. Herb Karpatkin, who's a physical therapist, who does these town hall style presentations with us, I think once a month, called Ask the Physical Therapist. And it's this coming Monday, the 26th at 4 p.m. Eastern Time. So please register for that at msfocus.org in the events tab. Again, we thank you, Doctors Gyang, Rosenthal, and Nolan, for your time, your expertise, knowledge, and that's, if nobody has any closing remarks, I guess we can just hang it up here, but I do hope to see you guys again soon.
Thank you.
Thank you guys so much.